Does anybody have any questions? Well, thanks for coming back, but does anybody have any questions from last week we want to go over? So I realized I left a few things out that I just wanted to talk about. So we discussed for quite a while the conduction system, and everybody knows that we said the dominant pacemaker was the SA node, right? And then there's tracks that go into the left atrium, obviously the right atrium, goes down to the AV node, which doesn't really, oh, I'm sorry, it is shown right here, okay? Then down into the bundle of His, splits into the bundle branches, and then these Purkinje fibers wrap around the entire wall of the ventricles. So the question is, what happens, I said if the SA node fails to fire, that the AV node would be the backup pacemaker. But what I neglected to mention is that actually any part of the atrium could decide that it's going to take over and start firing, okay? And we use some terms. We use the term of automaticity. Automaticity means that the heart muscle, the heart tissue, the cells in the heart has the ability, any part of the heart has the ability to initiate an impulse. So when we start getting into talking about the different EKG rhythms, I wanted to just explain that sometimes we're going to have a rhythm that actually originates in the atrium. The SA node is not the pacemaker site, okay, but it's just some tissue, some piece inside the atrium stepped up and started firing and did a good enough job that it actually caused the polarization of the atrium down to the AV node and so on and so on and so on. And the reason I'm bringing it up is that when we start looking at P waves, which is the wave that we see when the atrium depolarizes on the EKG, we're going to see different shapes of P waves. So typically if it's the SA node, it's a nice rounded P wave, which is what we always usually see, okay, but sometimes we're going to see ones that look different, okay, and that's because the pacemaker somewhere else in the atrium took over. So that's just one thing I wanted. And really, in all honesty, it's not just the atrium that has the ability. The entire heart actually has the ability, because we said that if the SA node fails, the AV node could take over, then the bundle of His could take over, then getting down into the Purkinje fibers can take over. So really, any place in the ventricle, if it had to, could take over. We said the problem, as we get further down the conduction system, what's the problem? As we get slower down in the conduction system, the heart rate that it's able to generate is slower, right? We said up top, it could be somewhere to 60 to 100. We start working our way down, 40 to 60, down to 20 to 40. So we always wanted to be as high up as possible, okay? But it can be any place along here. Now today, all we're probably going to get through is talking about pretty much non-dangerous rhythms. I mean, maybe moderately dangerous rhythms, but we really unfortunately have to have one more class to get into the heart blocks and the dangerous rhythms. We're never going to get through it tonight. Okay, if by some miracle we do, I'll try, but I really don't think that our attention span will be, good enough in 2 hours from now to really go through it. So we'll have to look at the end of the class on a date that we can use for the following. So everybody was okay with the conduction system and how it works? Okay, the pathways and stuff like that? Okay. So we're going to videotape again tonight. So everything, if you want for review, should be available tomorrow or the day after. Okay, so now we're going to talk about how do we apply a system to interpreting EKG strips. So there has to be a system. I mean, at some point you may get good enough, you could look at a rhythm, especially normal rhythms, and know right away it is. But in the beginning, it's nice to work your way through a system so that you take it apart step by step and know what you're looking at. So we'll look at a system. You don't have to use this system if you know a better system. It's just one of the systems that's out there. Okay. So we'll talk about how we're going to interpret it, the 5-step system, okay, how we're going to calculate heart rate without actually feeling a pulse, right? We have pulse rate, which is when we actually feel the pulsations by feeling somebody's pulse, and then we have heart rate, which is what we see electrically. Could somebody have a totally normal heart rate on the monitor and be dead? Yes. Absolutely, right? Remember, never trust a piece of equipment. Your eyes, your fingers, your ears are your best assessment tool. So just because the monitor is going along, it looks like a totally beautiful rhythm, doesn't mean the patient is not dead. Okay? We had situations where patients were on ventilators being transported, and the patient was dead when they left the hospital, and the patient was dead when they got to the next facility, and the patient looked like they were alive because the machine was breathing for them. So we can't trust a piece of machinery. We always have to trust our good assessment. Okay, so again, most important, look at your patient. Common sense stuff. When we look at a rhythm strip, we're reading it from left to right. There are little indicators on the EKG strip so you know which end is up, because nothing is sillier to start to interpret an EKG strip and then realize 2 minutes into it that you're looking at it upside down. And then you'll say, that's why it was so interesting. Okay, so we'll go through it. Again, in the beginning, avoid shortcuts. You know, anything you might think right off the bat, go through it, look at it in a very systematic manner. Okay, so we're going to look at 5 things. What's the heart rate? What's the rhythm, the regularity, okay, of the rhythm? Is there a P wave? Is it all the same shape? Okay, is it followed by a QRS? Is there a normal P to R interval? Remember, the P to R interval is the distance from what? The beginning of the P wave to where the QRS starts. So we're going to talk about the issues. What do we say the P to R interval tells us? Could be a problem with the block, but in other words, why is there that little bit of flat line between the P wave and the QRS that we typically see? Right, so the atriums, we said get rid of blood 2 ways, right? A little bit is contraction, most of it is just passive. So that little pause is letting the atriums completely empty so that the ventricles have something to pump out. And then again, is there a QRS complex? What's the width of the QRS complex? Does it look normal? Okay. Now, heart rate, we want to look at both. When we look at an atrial rate, which would be the number of P waves, and a ventricular rate, which would be the number of QRSs. We already established that the P wave, okay, is telling us the atrium contracted, and the QRS is telling us the ventricle contracted. Could somebody be alive without a P wave? Absolutely. Could somebody be alive without a QRS? No. Right? Your ventricles have to contract. Okay. Your atriums do not have to contract, but your but your QRSs have to be there. So we're going to have rhythms where we only have QRSs. We're going to have rhythms where we have P waves all over the place and they have nothing to do with the QRSs. And we'll talk through each step on what it is. Okay, so we said that the SA node is the dominant pacemaker. It beats about 60 to 100 times per minute. And then these 2 terms you already heard, right? Brady always means slow. So bradycardia is a heart rate less than 60. Tachycardia is a heart rate less than 100. So we're talking about that we have a normal rhythm, a normal EKG, where it's a little slower than normal or a little faster than normal. So what would be some reasons why somebody would have a totally normal EKG, a normal sinus rhythm, which is what hopefully we're all in, but it's going to be below 60 beats per minute? You're in good shape, right? That's why my heart rate's so slow. I have to say one thing. I found a get-rich scheme. So, you know, there's diet stuff. So there's diets, there's pills, there's this and that. All you have to do is videotape yourself and then watch it. So in the 2 weeks since I watched this videotape, and my wife will vouch for this, I have cut out 90% of the junk. Okay? Because I looked at myself and the only thought that came to my mind was, you are a walrus. That was the only thought that came to mind. So it's really good. And I also found out that I say the word okay about every 7 seconds. So I'm trying really hard tonight not to say okay. So, but it was eye-opening, to say the least. Okay, humbling. What else besides being in good shape? So in other words, the idea is if you exercise your heart doesn't have to beat as much. It's better in shape, it doesn't have to beat as much, right? And we all should strive for that. What else? Sleeping. Okay, so when you're in a restful state, actually when you eat, you tend to have a slower heart rate, because when you eat, remember we talked about there's 2 divisions of our autonomic nervous system. The sympathetic was speeding everything up and the parasympathetic was there slowing everything down. When you eat, when you feed and breed, okay, so when you eat and when you have sex, believe it or not, your parasympathetic system is activated, okay? When you have sex, actually both, your sympathetic and parasympathetic are activated, but when you're eating, it's mainly your parasympathetic. So when you eat, you tend to be a little slower, okay? So what else could cause our parasympathetic besides sleeping, eating? We could accidentally stimulate it. Okay, so we could accidentally stimulate it by straining to go to the bathroom, rubbing our neck. Those are all vagal responses, okay? We could definitely have medications that could slow down the heart rate, right? Beta blockers are a classic medication that would slow down heart rates. So we could have, where it's desired effect to keep the pulse rate down because people maybe are prone to tachycardias or their blood pressure is too high. Okay. What's the other big issue we said about beta blockers? What other patients should we be concerned about if they're on beta blockers? Anaphylactic patients. Remember, epi is a positive beta drug. So if somebody's taking beta blockers and has an anaphylactic reaction, your first dose of epi probably will not work to make them better. So this would be a situation where you probably would have to give repeated doses. Now, if you have a history of anaphylaxis, your doctor should not put you on beta blockers for control of your blood pressure. But let's say you don't know you have a history of anything, and he puts you on a beta blocker, good cheap medicine, control your blood pressure. Now you get stung by a bee and you have an allergic reaction. We come along and give you epi. and you're saying I'm not feeling any better. How would we know the epi is not working, besides the patient telling us they're not feeling any better? What vital sign would not change? Heart rate. Right? If you gave any one of us a shot of epi right now, our heart rate's going to go 40 or 50 points immediately above our baseline. So if that does not happen, it's either the epi's expired, you gave it wrong, which the epi auto-injectors, I would say you're never going to really give it wrong. But now we're doing the check and inject. We're finding people think they drew up the medication and they really have a big bubble of air in the syringe, and they're not watching what they're doing. If they don't realize that they have air instead of medication, they may be giving the patient a placebo, where they're not going to really be getting any better. So that's one of the downsides of the check and inject. Okay, and the other time where you'll see bradycardia is a closed head injury, right? When somebody has a closed head injury with rising intracranial pressure, remember the vital sign changes are the opposite of shock, right? In shock, we see tachycardia and hypotension. In a closed head injury, you have that Cushing's triad where you see the pulse rate starts to drop, okay, and the blood pressure starts to go up. That's caused because when the brain is herniating and pushing down, right, on everything, it pushes down the vagus nerve. Anytime you have bradycardia, it's the vagus nerve. You can always blame the vagus nerve, pretty much all the time. And so what's happening when you have that brain herniation is pushing on the vagus nerve, and that's what's stimulating the bradycardia. That's also why when you have a closed head injury, you see pupillary changes because it's pushing on the oculomotor nerve, which controls your pupils. So everything you see in a closed head injury is related to the brain herniation because of the pressure. The hypertension comes when the brain is being squeezed, not a lot of blood is going to the brain, right, because it's being pushed on. So the brain says to the body, I'm not getting enough blood, raise the blood pressure, not knowing that it's probably making it all worse, but that's where you get the hypertension from. So that's another time where you may see the tachycardia. Obviously, fright, you'll see tachycardia. Okay, any kind of exertion, you'll see tachycardia. And then the big thing we need to realize is that tachycardia sometimes is actually life-saving, right? If you're in shock, tachycardia is compensatory to keep your blood pressure up. Your heart rate increases. So in that case, you would never want to do anything to slow down the heart rate because it's, somebody's dehydrated, somebody's in shock. Even somebody's got a pneumonia and they're probably a little dry because they're breathing real hard and real fast. The tachycardia we see is what we call compensatory, which means it's good. We don't want to do anything to suppress it. A lot of times post-cardiac arrest, a patient comes back and you'll see they come back in what's called a hyperdynamic state, which means their pulse rate is up and their blood pressure's up. And inexperienced people would say, oh my God, look what I just did. I got this guy back and now his blood pressure's high and his heart rate's fast. I need to slow everything down. Remember, they were just dead. You don't slow it down, right? Because what is causing them to come back tachycardic and hypertensive? Well, the epi, right? Well, the epi we gave them in the hopes of re-stimulating their heart. And what's going to happen as the minutes go by and the epi starts to wear off, you hope that the heart rate stays somewhere around, 80 to 100. So you would never suppress. If you ever had a cardiac arrest save, you'd never play around with it. In other words, dead is dead. If you got something that's generating a pulse, you're never going to try to slow it down or anything like that. Okay, so any questions on the bradycardia, tachycardia? So let's look at a rhythm strip. So the first thing is that the rhythm strips we look at nowadays are being generated by very fancy computers, and it's built into the monitor defibrillators we have. So the days of just looking at, a nice strip going across are probably gone. We don't see that anymore. I don't think there's even a machine out there that just prints out just a nice long rhythm strip. So we're going to see a multi EKG piece of paper that has numerous things on it. There is a way where you could get along the bottom just a lead 2 strip. Lead 2 we like. Okay, remember we looked at that triangle they drew on the chest and it was showing all different views, like a camera looking at all different views of the heart. Lead 2 we like because most of the times everything's upright, which is the way we like to see it. Okay, and it's a clear way of saying it. So there is a way of putting it in there if you want to, where you would see, lead 2. A lot of people look at lead 2, lead 3, and lead AVF as just a 3-lead EKG. But most of the times now we're looking at 12 leads. So what they're showing you here is that on the EKG paper, there's usually little lines, okay? Little dark lines. So here they're adding these little other ones, but there should be like one line here, one line here, one line here. In between each of these 2 lines is 3 seconds. So in between 2 sets of dark lines, cross out these ones over here. But like this one, and this one over here that's kind of hidden in the shadow, that would be 6 seconds. If you counted the QRSs that fell in 6 seconds and times it by 10, okay, what would you get? A minute of heart rate. But when is that accurate? The EKG has to be what? Regular. Right? If you're a grossly irregular EKG, looking at 6 seconds of it does not give you an accurate reading. So I personally would much rather get a pulse rate, is feel the patient's pulse, because it tells you two things. Is every one of these actually conducting and making a heartbeat? There's no guarantee that every complex is actually conducting. That's electrical. And then mechanical is when you feel the pulse. So you want to know electrically is it working, but you also want to know mechanically is it conducting and making a pulse. So I think it's really a good idea. It's fine to look over at the monitor and get a heart rate, but see if you get a pulse rate that corresponds to the heart rate on the EKG, and that'll give you a lot of information. So this is just one way they're showing you, which is they call the 6 second. So you're going to look at 6 seconds, okay, of it, times it by 10. Again, if you see it grossly irregular, useless. Not a good way of doing it. So they're just showing you again 6 seconds. The lines are on the paper. Every paper has a different little symbol. Sometimes they have triangles on the top, but they usually have these little symbols which will show you the 3 second intervals. So if you find 3 of them in between the outer ones, will give you 6 seconds. The height of the EKG tells you amplitude, tells you how much electricity is being generated by the heart. We don't typically use that for anything, but if you went to the doctor and they said you had a low amplitude EKG, one of the things that could be wrong with you, and it could be, there could be nothing, it could be benign, but one of the things that could be wrong is that you have what they call ventricular hypertrophy. Hypertrophy means the muscle is what? Thick. Remember we said already the heart muscle is the only muscle that you don't want to be thick. So when you have ventricular hypertrophy, the amplitude of the EKG tends to be very low. Why? Because the muscle is so thick, it's hard for the electricity to travel through it to where the electrodes are. So it just becomes harder to get that spike. So that might be a sign of ventricular hypertrophy, which again, in some people it's watchful waiting, but people who have ventricular hypertrophy are also at risk for sudden cardiac death. For some reason, when the heart is very thick, the electricity doesn't travel through it well, and these are people that also sometimes have sudden VFib arrests. These are people that tend to go into congestive heart failure because their hearts don't contract. So the only way to prevent ventricular hypertrophy, if it's not genetic, is to stay in shape, because then your heart doesn't have to beat as hard to circulate blood, and if your heart doesn't have to beat as hard, it doesn't get very thick. So really, being out of shape is how you wind up, most of us will wind up with ventricular hypertrophy. Okay, so here's what I was telling you about before. This would be off a LifePak 15, a 3-lead strip. Here they happen to have lead 2, up here, lead 3, and they're looking at CO, okay, for some reason. We typically don't monitor CO because that requires putting a device, a special nasal cannula or something on the patient, and it's expensive. We don't have to monitor CO2 on a patient unless they're in respiratory distress. So we would usually have 2, 3, and AVF over here, and they're showing you go across this way. Now, over here, it's always going to show you, okay, the time, the millivolts of electricity that are, being generated. And you see the difference here. It's got an 86 and it's got a 109. One is the heart rate probably off the pulse ox, and then one is the heart rate off the monitor. So you're going to see, now here you got 2 different devices looking at heart rate, and you have discrepancies already on what the heart rate is. So that's why it's always best to feel a pulse and see, where it's at. Okay, here's what we look at when we look at a 12-lead. Okay, so one is that all the new 12-lead machines have a computer built into it that interprets the rhythm. It's, I would say, overly cautious. It puts out a lot of fancy terms and stuff like that, and sometimes the patient's in totally a normal rhythm. But you see abnormal EKG unconfirmed. It's very famous of saying unconfirmed. I think that's its lawyer side of it, making sure that it's covering itself. But it says wide QRS tachycardia, left axis deviation. We're not going to get into axis deviations because in all honesty, I don't 100% understand them myself. But axis deviation, when we're looking at 12 leads, is just telling us the way the heart is sitting and the way it's conducting, okay? And it also has a left bundle branch block. So the bundle branches are what? The 2 branches that go down into it. The left one is blocked. No impulse is going down. The left one is stopping. Why is this person not dead? If their left ventricle is being blocked, right? No impulse is depolarizing their left ventricle. Why are they not dead? Because your right bundle branch eventually depolarizes the right, and then what? It doesn't stop at the septal wall and say, I'm only in charge of the right. Right? It's like us. I'm only going to handle, Ramapo. I'm not going to go into Clarkstown because I'm a Ramapo unit, right? And stuff. So, but it's not that way. If the right depolarizes, okay, when it hits the septal wall, if it finds the left side not depolarized, it'll keep on going. If it finds the left side depolarized, it'll stop. I'm not going to step on anybody's turf, and it'll stop. But if it finds it underpolarized, but what's going to happen to the QRS now if that had to happen? If the polarization of the left happened from the right wrapping around versus the left doing it itself, what has to happen to the QRS? The length of it has to get wide, exactly, because it took much longer to get that whole heart to depolarize. So right now you already understand one time you're going to see a wide QRS is when you have a bundle branch block. Okay, would be one situation. And people can walk around every day with a bundle branch block and not even know it. Okay, if they had two bundle branch blocks, would they know it? Yeah. No, they'd be dead. So, right, they wouldn't know it, but but it would be their demise. So you can't have two. Okay, you can have one, and actually, believe it or not, sometimes it can come and go. So you could have it, and then like I had one guy had it, we brought him to the hospital, and I'm like, oh, he has a bundle branch doc. And the doctor was like, really, where? And I'm like, oh, back in the ambulance. Luckily we were able to print out the EKGs that showed it, but his came and went. So it's interesting with this one, okay, is that the machine is right. This guy has no P waves, right? He's actually in a ventricular tachycardia. So this is where the ventricles have, for some reason, gotten really upset, very, very irritable, and they've decided to fire on their own. And then they did the opposite of what we were told they're going to do. Instead of firing at 20 to 40 beats per minute, they're firing pretty fast. Okay, the heart rate here is where? It's somewhere up here. 197 beats per minute. So this is a dangerous rhythm that very rarely happens, okay? But the ventricles have just kind of gone out of control, and they're beating out of control. So we have two issues. The atriums are not participating in this, so we have less filling of the ventricles because there's less blood coming from the atrium down. The other issue is that when we have the heart rate going that fast, what else I said affects the cardiac output? When the heart rate's going over 100, the ventricles don't have time to do what? Refill with blood. So you have what's called decreased ventricular filling time. So this guy probably is unstable. What's it? Yeah, exactly, double whammy. So this guy is probably unstable. Okay, and the treatment when they're really, really unstable is cruel. What you actually do is shock their heart when they're still awake. So hopefully he's not that unstable and we have time to give him medications. We have a medication called amiodarone that may work in this situation. But if he's really going out of picture, barely talking to you, the treatment would actually put the same defibrillation pads like we always use on the patient. Okay, put the machine in a special mode where it actually looks at the EKG, not when we press the button, it decides when to shock. We tell it to shock, but it looks for the EKG, a certain part of the EKG, and then it shocks the patient. And trust me, after that, they're going to be wide awake, they're going to be in terrible pain, and they're going to be like, why did you do that to me? So you would think, why don't we sedate them before we do it to them? The problem is if they're unstable, the drugs we use to sedate people only make them more unstable. So you can't sedate them, but afterwards you would definitely want to sedate them, if not give them analgesia to relieve their pain. So over here, if you look, you got a couple seconds, like 3 seconds of lead 2, 3 seconds of lead 1, lead 2, lead 3, AVR, AVL, AVF, okay, and then the V leads, which are the chest leads. There is no continuous tracing on this one. So this is a true 12 lead. You're looking at 12 different views of the heart. All of them look bad, okay? But again, lead 2, the one we like, is nice and clear. So are the V leads, but they're nice and clear in what we would want to see. Okay, so another one, acute myocardial infarction suspected, So sometimes when somebody is having a heart attack, okay, what we would see is that the ST segment, okay, which this is the T wave, the S wave, again, remember you have QRS, so the S wave is one of the waves onto the QRS complex, is elevated. So here it shows it best where when they say it's elevated, it's that it's not coming down. You see how the T wave is not coming down, okay, onto the S wave. It's not getting it back. This is what they call the isoelectric line. If you drew the flat part across, can you see that this is not getting back down to the isoelectric line? So that whole complex, that whole segment is elevated, and that's something that you would see in somebody who's having an acute infarction.
The S is down, but the T is not.
So, no, if you look, right, so it's a little hard to see here, but the Q wave, is this vibrating or is it me? It's vibrating, okay. I thought I was having a seizure. Okay, so. Why is it vibrating so much? So the Q wave is the downward deflection right in front of the QRS. The R wave, okay, is going up. The S wave is going back down. So then this line, technically, the start of the T wave, should really be coming all the way down here. Can you see this little segment where it's raised? So that would be called ST segment elevation. So that's all you would be looking for. I mean, sometimes it's very dramatic. Like I think it's much more dramatic maybe over here. And sometimes they call it tombstone. You know, a tombstone is kind of like rounded like that. It'll look very, very, very distinctive. So this one is giving you a diagnosis, right? Suspected arm lead reversal. Okay, interpretation assumes no reversal. So for some reason it's thinking you put the leads on. Okay, it's a normal sinus rhythm of first degree AV block. All the first degree AV block is, you see the P waves where you can see them? You see how far they are from the QRSs? So normally they should be a little closer. We're going to talk about them in a second. Okay, and then right superior axis deviation doesn't matter. Okay, ST elevation, consider inferior lateral injury. Okay, with acute infarct. So it's basically telling you that these are the inferior lateral leads. Okay, over here and down here, and that's where the injury to the heart is occurring. So this would be a patient with this that we should be considering to do what for this patient? If this was the EKG and this guy has to be telling us he's having chest or abdominal discomfort, our treatment should include what? Okay, so depending on his pulse ox, some supplemental oxygen, right? If his pulse ox is really 94, 95% or greater, I would put him on a liter or two of nasal and I'd leave it at that because he's satin fine already. He doesn't need high concentration oxygen. Most of the data now says that high concentration oxygen would actually be detrimental to the patient if they're having a somewhat normal pulse ox. But absolutely what would be important is chewable baby aspirin, right? Non-enterically coated chewable baby aspirin. And what do we give? In New York State, it's 481 milligram. What's it in New Jersey?
325.
4. Okay, so each one is around 81 milligrams. 81 point something, so they come to 325. Remember, it has to be non-enterically coated, and we have to tell them to do what? Chew it before they swallow it. And don't assume that patients are going to know that, because typically when somebody puts a pill in their mouth, they swallow it. And if they chew it and swallow it, the onset is less than 15 minutes to get to work. And that's what we really want, because most heart attacks are caused by a plaque rupture. And because there's a rupture inside the blood vessel, it's not a rupture where the blood vessel is leaking anything. It's an interior rupture. The body sends platelets to it, and that's what clogs up the artery. Aspirin interferes with the ability for the platelets to stick together, so you're going to slow down the progression of their heart attack. So the biggest decreaser in mortality of a heart attack patient, doesn't matter who gives it, but that is aspirin. So if they take it, great. If we give it, even better. You don't want to wait till they get to the hospital, have them take it, because you waited a half hour, and now they could have damage from it. Okay, sure. So very good. The contraindications would be a true allergy and anaphylactic reaction to aspirin or any of the products in aspirin. Okay, so unless you're over the age of 40, you may have never taken aspirin, because what happened? Rye syndrome came out, right? I don't know how many remember. Like, I grew up on chewable St. Joseph's baby aspirin, as probably a lot of you did. Okay, but at some point, I think it was in the 70s, they said that taking aspirin with a fever could cause a neurological event called Rye syndrome, R-E-Y-E-S. And all of a sudden, Tylenol became the treatment of choice. There was no pediatric Tylenol, I don't think, before then, and it became the treatment of choice. So I'm sure that McNeil Pharmaceutical, I shouldn't say that, I'm sure that somebody, invented that, because it went away pretty quickly, and all of a sudden Tylenol came to the forefront. Okay, the second way we could do it is the R to R, okay, which I don't particularly like, but what it basically means is that you would look for an R wave to fall on a solid line. So none of these actually fall on an exact solid line, but let's pick this one. And then you would count how many boxes. So we got 1, 2, 3, 4, 5, 6 boxes till the next one. So you divide 6 into 300, and it would give you a rough idea of what the heart rate is. So again, I've never used this one. It's one that's out there. It has to be regular, but that's another one that's out there. I don't know anybody that does use it. There might be some people that use it, but that's another one. The one I use is this one. So this involves a little more remembering, but you have to remember 300, 150, 100, 75, 60, 50, 40. Okay? So if you remember the, ample and the sample, you can remember this, right? All the other stuff we had to remember. So what you would basically do is look for, and this is all, I don't want to date myself, but this is like all old stuff, because nowadays what happens? You have it on a piece of paper. Right? I mean, I can't tell you how many tests I took or how many tests I've given where I made people figure out heart rate. And then finally one student said, I don't want to be a wise guy, but why do we do this? It's all printed out nowadays. And I'm like, the same reason why you should know how to read a map, even though you have GPS in your car, because you never know. They may shut the satellites off, So, but this is one way. So you'd look for a QRS that falls on a solid line. The next solid line, if there was a line, a QRS here, the heart rate would be 300, 150, 100, 75, 60. So the next one is falling between 60 and 75. So you could say the heart rate is probably somewhere between 65 to 70, okay, on this patient. So this is just another way. So again, start solid. You have to find a QRS on a solid line. 300, 150, 100, 75, 60, 50, 40. So if the next complex was only in here somewhere, it would be heart rate would be someplace between 40 and 50. So that's the one I use, but the machine, like I said, nowadays prints it out. Okay. Rhythm means is each complex, this would be a regular rhythm. The time between each complex is fairly regular. Just like if you felt somebody's pulse, the pulse impulse is regular between each one. Okay. So we have a situation where it's regular, and then we have irregular ones. Now we have rhythms that are irregular because the heart is totally out of sequence. We also have rhythms that are irregular because every so often the patient has an extra beat. So we're going to talk about those as we go on. So doesn't say one's better than the other or one's worse than the other. You have to know the EKG, and you have to see how the patient's tolerating. And remember, we're never going to treat an EKG. We're going to treat how the patient is tolerating the EKG they're in. So there's now in even some of the more advanced courses, instead of all the treatments being drugs, that one of the treatments on the test is expert consultation. So what does that mean? It means that if you're faced with a rhythm, okay, that you don't know what to do, and the patient's somewhat stable, don't wing it, okay? Send it to, mainly in pediatric courses, they'll talk about expert consultation because there's very few pediatric cardiologists. So if you have a pediatric patient in abnormal rhythm and they're tolerating and they're stable, the right answer is not to try to treat it yourself, is to send a 12-lead, fax the 12-lead, or transmit the 12-lead to the pediatric cardiologist and have them interpret it and tell you what you should do. Because, there's certain things that we're not going to be experts in. Okay, so if we look at this rhythm here, okay, and we start measuring along, just quickly looking at it, does it look pretty regular? Yeah, doesn't look really terribly irregular. There's P waves in front of every QRS. Okay, there's QRSs all over the place. So this would be somebody who has a normal rhythm. The only thing that would kind of strike me just looking at it very quickly is that the P waves are a little pointy versus being totally rounded on top. Okay, now I'm missing something. What am I missing? That doesn't mean anything. You can't tell anything about any of that stuff unless you're looking at 12-lead. So you're never going to look at anything just on one view of the heart because it may just be that one view of the heart. So you'd have to look at it on a 12-lead, okay? But I wouldn't really worry about it, and I wouldn't really call it real depressed anyway. It might be a little depressed down here. But the P waves are a little pointy. So is it still originating in the atrium? Yes. Can we 100% say it's originating in the sinus node, SA node? No, because usually it's a little more rounded. So this could be an impulse where instead of the SA node, someplace else in the atrium is firing. Now, the old way of telling rhythm, okay, was to use EKG calipers. I still have mine. I'm sure Bob still has his too. So we could all the dinosaurs can raise our hands, okay? But like I said, I can remember taking those things and you spun them from one to another, and when somebody was falling asleep in class, you used to jab them in the ass because there's little pins on the bottom, and it will wake them right up. So, but this was the way, and in your little pouch, your little Batman pouch where you had all your other little toys, you used to have that, okay, in there, and that's how you would normal, and there's still people, that use it, and that's how you would measure. So if you wanted to measure the distances from the R to R, right, the QRSs to QRSs, you just find two and then see if the next one fell where it should be and the next one. So that's the way we used to do it. Now the machine basically does that electronically and tells you whether the rhythm is regular or irregular. Okay, so we have some different types of patterns. So we have regularly irregular, okay, where there's probably an extra beat falling the same time throughout the rhythm. So every fifth beat, there's an extra beat. So it's regularly irregular. It happens at the same interval every time. Okay, so that's one way we could have it. Occasionally irregular. So that probably means there's an extra beat just popping in, no rhyme or reason, every so often. Okay. Then we have irregularly irregular. And that is typically one of the rhythms that it's usually irregularly irregular is atrial fibrillation. And atrial fibrillation, okay, the atrium, remember how in ventricular fibrillation we said the ventricles are just quivering? In atrial fibrillation it's the same thing. So what you basically have is no organized electrical activity in the atrium. So you got this hundreds of little electrical impulses firing, doesn't actually generate a contraction of the atrium. So when you look at the EKG, you see lots of little squiggly lines in front of the QRS, and because there's no steady impulse coming from the sinus node down into the ventricles, you don't get a regular rhythm because the ventricles don't necessarily know which one of those crazy little impulses is going to be the one that gets it down there. So what do we say is the danger of somebody in atrial fibrillation? So first of all, people live day in and day out in atrial fibrillation. But what are some of the dangers that people face if they have atrial fibrillation? Okay, so the main danger, okay, would be blood clots, right? So to prevent the blood clots, they go on anticoagulant type of medications. And we know the issue with anticoagulants is that too little, they develop clots. Too much, they bleed. So you always have to be very cautious with a patient, okay, who's in atrial fibrillation. The other issue is that since the atriums are not contracting, there's going to be less blood going to the ventricles. So if somebody's in AFib and goes into what's called a rapid AFib by definition is a ventricular rate over 100, their blood pressure is going to start to decrease because they have decreased ventricular filling time, plus they've lost the atrial activity coming down to the heart. Okay. Now, if somebody was in AFib and they threw a clot from their right atrium, what emergency would that occur to them? A pulmonary embolism, right? Remember, it would go right atrium, right ventricle, pulmonary artery, okay, and they would throw a PE. They have a pulmonary embolism. Those patients typically complain of what? Sharp chest pain, okay, and then shortness of breath. Their shortness of breath is not a blockage of air coming in their airways. Their blockage is what? The problem is that the blood can't get from the right side of the heart to the lungs to have gas exchange, so their oxygen level drops, so they have the sensation of shortness of breath, but they're moving air fine. It's blood flow, right? A pulmonary embolism is blood flow. It's a form of obstructive shock. If they throw a clot in their left atrium, it's going to go left atrium, left ventricle, into the aorta. The aorta arches, and you got the blood vessels that go up to your brain, and they're going to have a stroke. So neither one is good, okay? But that's why it's very important to be well anticoagulated. Okay, so what do we have here? So we have a P wave, we have a QRS, okay, and we have a T wave. The heart rate is somewhere 1, 2, 3, 4, 5. Heart rate's around, say, 60. Okay, so let's make it 62. So we could say it's above 60. Okay, we have a P wave before every QRS. We have a nice narrow QRS. The distance of the QRS, can you make out the little boxes between the big boxes? So the little boxes, the distance between each little box is 0.04 seconds. There's 5 little boxes inside of one of these big boxes. Okay, so that means this is 0.2 seconds. Okay, and if you took 15 of these boxes, that would be 3 seconds. If you took 30 of the boxes, that would be 6 seconds. So when you were measuring this in here, there should be 30 boxes, okay, across, and that would give you 6 seconds. When we look at the width of the QRS, it should be someplace between less than 0.10. So now you have to take your magnifying glass. You have to say 0.4, 0.8, 0.12. So somewhere right in here, this is looks like pretty much on the 0.8 line. So this is narrower than 0.10, so it's a normal QRS. Why are we concerned about normal QRSs? It's telling us that the impulse conducted through the ventricle at a normal rate. If it was slow, we said it's going to be a wide QRS. I don't know what quite it means if it's fast. I mean, if you get a real narrow QRS, I don't know what the significance of that is. Okay, so again here, same sinus rhythm. But what do we notice right off the bat? We got 1, 2, 3, 4, 5, 6, 7, 8. So here the heart rate's a little faster. So I guess they were calling this a sinus bradycardia. So I sped it up a little bit, but I think for teaching purposes, they wanted to call this a sinus bradycardia. So let's make, instead of 62, let's make the heart rate 52 on this one. Okay. If we do the other way, do we have one where it falls out on a solid line? No, but we can fudge it. So this would be 300, 150, 75, 60, 50. So if you did the other way, the heart rate's going to come somewhere between 50 and 60. So depending on how you counted, and this one is 1, 2, 3, 4, 5, 6, so 60. So somewhere between 50 to 60 would be the heart rate. On this one, we said the heart rate's 80. Do we have one where it's on a solid line? So this one, 300, 150, 75, 60. So I don't know why it's not, I'm doing it some wrong. So 300, 150, 75. 100. What did I do wrong? 300, 150, 100, 75. Okay, so the heart rate is someplace to the left of 75, so it's probably the 80 is accurate. So it's just two ways of figuring out the heart rate. Okay, so the P wave we said, okay, is when the atriums are contracted. It's the first upward deviation on the isoelectric line. It should be rounded and upright. Okay, if it's sinus and origin, okay, and it basically means that the SA node, if it's rounded and upright, is the dominant pacemaker firing regularly. And this is called a sinus rhythm, and a normal rhythm is either called RSR or NSR, regular sinus rhythm or normal sinus rhythm. So that would be the abbreviation you would see. So are P waves present? Are P waves occurring regularly? Is there one P wave for each QRS? So those are the questions we're going to ask about the P wave. And then we wrote, are the P waves smooth and rounded and upright in appearance? So that would be a sinus rhythm. If they're inverted, it means that it probably happened further down, more towards the junction. So picture now, if it was the AV junction, not up here, but lower, that depolarized, what's going to happen? The wave is going to go in both directions. So when the wave starts to travel up the atrium backwards, instead of going downward, the P wave is going to look at what appearance? Inverted, upside down, because electrically what's happening? It's going opposite of the way it should be going. So when it's a junctional rhythm, you could have no P waves, you could have inverted P waves, or you could have P waves that sometimes actually fall after the QRS. And I'll explain that to you when we get to the different complexes. The ones that fall after the QRS, most of us are going to miss because it's hidden a lot of times in the QRS. Okay? So I wrote rounded P waves is the SA node, pointed P waves somewhere in the atrium, okay, outside of the SA node, and then inverted P waves typically down below the atrium in the junction, okay, or at the bottom of the atrium in the junction. So those are all the different ways you could see it. And again, if it's no P wave, then that could also be a junctional rhythm. Now, do all the P waves look the same? So what about if you have 5 different, in a minute you have 60, P waves, and there's 10 versions of the P waves. Okay, so they, you got 10 different ones appearing. So they're all different ones coming up. What is that telling you? Multiple foci, the term is foci, or multiple sites, F-O-C-I, multiple foci inside the atrium are all randomly firing. So instead of one guy saying, everybody else knock it off, I'm going to take over, it's not the SA node, remember, it's the atrium. Instead of one little spot in the atrium saying, I'm the biggest, I'm the strongest, I'm going to do it, they're all fighting. It's like 10 guys in the room, nobody can agree on anything, and they're all trying to take over. So now you're going to have multiple different appearing P waves. And the term for that is called WAP, wandering atrial pacemaker. So in other words, the pacemaker is wandering throughout, and if it's fast, it's called MAT, multifocal atrial tachycardia. So in the multifoci atrium tachycardia. So all it depends on is what the heart rate is. If the heart rate's below 100, it's WAP. If the heart rate's above 100, okay, it's MAT. That's all it really depends on. And it'll be a test on whatever we do next. No, I'm teasing. Okay. So again, here we have some P waves, okay? Do they all look exactly the same? Pretty close, okay? Maybe not exact. This one seems to be a little pointy than the other ones. We don't get worried about one little deviation, okay? Heart rate looks to be about 80-ish, okay, right? We got 4, 8. So there's a P wave in front of every QRS, normal P to R interval, normal QRS, T wave. Until we know otherwise, right now we're going to call this a normal sinus rhythm. Okay. If the heart rate was 42 and it looked exactly like this, we'd call it a sinus bradycardia. If the heart rate was 140 and looked like this, we would call it sinus tachycardia. So, okay, the P to R interval. Okay, so it's from the onset of the atrial contraction to the onset of the ventricular contraction. So the P to R interval, okay, is the distance from the onset of the atrial contraction to the onset of the ventricular contraction. That would be the whole P to R interval. So we got 1, 2, 3, 4. So it should be less than 0.20 seconds. So that one is around 0.16 seconds, right? Because each box is 4. So this would be an okay P to R interval. If it's wider than 0.20, then we would call it a prolonged one. So what is it telling us? Where do we see this pause? What's causing this little pause? Over here, we said the AV junction, that when the impulse comes from the SA node and it hits the AV junction stops it for 1 second and then lets it through. And that lets the atrium completely empty. So if it's longer than it should be, then what is the AV node doing? It's a little sticky, it's holding it for a little longer than it should, and then it's still letting it through. So all it's telling us is it's a sign of probably a little bit of a diseased SA node. AV node. That's all it's telling us. Nobody in the world calls 911 or goes to their doctor saying, I feel like I have a delayed AV node. So what's going to happen is you're going to pick them up for something else, and you're going to put them on the EKG monitor, and you're going to say, oh, does your doctor tell you have a first-degree AV block? Okay, and they're going to say, no, is that dangerous? That's why I never say anything. I say the opposite, and I say, so what did the doctor say about your heart? Is everything good? You know, healthy, looks fine here. Any problems? No, everything's fine. Okay. And then when you get to the hospital, you could say, you know, oh, by the way, it looks like they might have a borderline first-degree AV block. Years ago, we called that a separate rhythm. We used to say they were in a first-degree AV block. Now we call it a normal sinus rhythm with a first-degree AV block to reflect the fact that there's nothing bad about it. It's a normal rhythm where the conduction through the AV node is a little delayed, so we don't make a big deal about it anymore. There are going to be a lot of other blocks that we make a little bit of a bigger deal about, because obviously if the AV node starts getting real sticky and slowing a lot of impulses from getting the atrium down to the ventricles, what could happen to the patient? The heart rate could do what? Dramatically start to slow, and those are all the heart blocks that we'll talk about. Okay, so the Peter-R interval typically is somewhere between 0.12 and 0.20 seconds, about 3 to 5 small boxes. Okay, so just another thing you're going to look at. So are the Peter-R intervals greater than 0.20 or less than 0.20? Okay, you know, we'd want to know, are they between the normal 0.12 to 0.20? And are they constant all the way through? Is it the same Peter-R interval all the way through? So
It's less than 0.12?
if it's less than 0.12, I guess it would mean that the AV node is not delaying the impulses through. Okay, for some reason, it's not holding on to it, which could mean there's probably less atrial blood flow getting from the atriums, but I've never really seen that, so I don't know if that's possible. It could, I mean, anything's possible, but I've never seen that. Okay, and then going to the QRSs, okay, so the Q is the first one, R is the upward, S is down. Do they have to have all waves? No, remember we looked at the other class where we only had 2 of the waves. Typically you're going to have at least 2, and typically you're always going to have an R wave, although in some leads you may only have a downward facing one, depending on the lead you're looking at and the view of the heart. Okay, so that's all typically there. So usually you have an R and an S. The Q wave is the one that's usually not there. So it'll be the first negative. So the Q wave would be going down, R wave, S wave. So you typically have an R and an S. Q wave may or may not be there. One of the things you may hear in the hospital is they'll say they have a non-Q wave MI. Okay, you may hear somebody say that. So what that means is that usually after you have a heart attack, so it's not going to be unless somebody sat at home for hours, but after you had a heart attack, say 3 or 4 days later, the muscle is damaged a little bit, and as it's recovering, people tend to develop very pointed, prominent downward Q waves. Sometimes when people have heart attacks, that doesn't happen. So they call it a non-Q wave MI. I don't know the significance, you know, as far as is better or worse, but you'll hear sometimes saying that they have a non-Q wave MI. Okay, so the QRS is greater than 0.10. That would be considered wide, which would mean there's what? Increased time to get the ventricles depolarized, or what's the other thing it would tell us? That the ventricles are the pacemaker site. So there's 2 things it could tell us. One is that the atrium was the pacemaker site. When it started to get down towards the ventricles, there was a delay in conduction where one side didn't conduct, the other side did. And then eventually the rhythm wrapped around, the impulse wrapped around. Because of that, you get a wide one. Or if the ventricles become, like if someplace in the, is there anything to write with? No. So if the so picture there being a circle as the heart right here, right? So, and then we have a line, this is the ventricles. Let's say that nothing's coming down from the SA node down to the ventricles, but that as a last-ditch effort, some part of the ventricle just fires. Now, normal conduction, we said, is bundle of His, bundle branches, and it wraps around the Purkinje fibers. If just some random guy in the middle of the ventricle decided, you know, nobody else is beating, I'm going to fire, what does that impulse now have to do? Work its way all the way around. What's going to happen to the QRS? Wide. Remember, the EKG complex is very fast if it follows the nerve fiber pathways through the heart. Anytime something happens out of normal, it's going to slow down because you have that all or nothing phenomenon where it very slowly propagates around. So the 2 times you're going to have a wide QRS is if there's a bundle branch block, which slowed the polarization from the sinus down into the ventricles, or if the ventricles themselves became the dominant pacemaker. So ventricular rhythms, like that VTAC we saw, typically would have a wide QRS because the ventricles are the dominant pacemaker site of the heart. Okay, and then we have the ST segment, okay, which begins at the end of the QRS, okay, and ends with the onset of the T wave, okay. It's typically the isoelectric line. So if we're looking at here, the ST segment would be this little bit of, well, it's not really flat here, but the little bit of flat line you should see in between there, okay? Don't worry about the J point and all that stuff. When we're doing, looking at bundle branch blocks and stuff like that, you would look at something called the J point, okay? It's where the QRS meets the ST segment, okay? And with that ST segment, acute injury typically shows an elevation, ST segment elevation, okay? Depression could be an old, like an injury after it occurred, or when we're looking at 12 leads, remember I said the 12 lead, I don't want to go too far back, but remember we said the 12 leads are, oh yeah, I'm going back, let's see. So we said 12 leads are like cameras looking at the heart. So if you're looking, let's say, at the front of the heart over here, there has to be a view of the back of the heart somewhere. Well, that's not a good one because the anterior view, only way you would see the posterior view is if you put the electrodes where? On their back. I've done that once. And it took so long to figure out what was what because the best thing to do is actually put the front electrodes on and leave them there and then go behind them and keep on looking over them and just put it on backwards, facing that way. But let's say it's a lateral, okay, wall. So if the lateral wall is showing you one thing, you may be able to look on the opposite EKG, okay, and see what they call reciprocal changes. So in other words, if there's ST elevation over here, there may be ST depression over here. So that's what they're talking about when they're talking about reciprocal changes. So if one side's up, one view is up, the opposite view should be down. So, we start talking about, I wasn't really planning on getting into heart attacks. I completely forgot about that one. But we'll see maybe after at the next class that we have a couple of minutes, we'll look at some heart attack EKGs. Okay. So again, the T wave is the ventricular repolarization. So that's when the ventricle is repairing itself, getting ready for the next complex, okay? And it's typically an upright, okay, deflection after the QRS. And we said the U wave, I've never seen, but the U wave may be a little tiny bump after the T wave, okay? So that doesn't really matter to us. Now, artifact is what's going to interfere with the ability for us to make a clean determination. The machine will tell you if it senses artifact. It will give you a message. It could be, it'll say, skin tremor. So that would be one reason, if the patient's shaking a little bit. It could be 60 cycle interference. It could be that the electrodes, remember I talked to you that, believe it or not, the electrodes have a lifespan. So if you get that family pack of like 500 electrodes or whatever it is, 100 electrodes, and they've been sitting in your bag for more than a month, they're really not good anymore because the gel that conducts the electricity through the skin starts to dry up. So you wouldn't not get the same accuracy of your tracing as you would.
Or sometimes if someone's in the back touching the patient.
Yes.
Picking up.
Sure. Yep. If you're giving a patient a hug, you may throw it off. Okay. You're moving the patient. The wires are resting on the floor of the ambulance, and you're bouncing around. You may get some artifact. So artifact can be seen where it looks very, very chaotic. Now, some people may look at this and say, well, that looks like atrial fibrillation. But the rhythm is regular. And atrial fibrillation is going to be, we said, irregularly irregular, which means that not only is the atrium chaotic, but the distance between each QRS is going to be varied. So this could not be atrial fibrillation because the ventricular rate is too regular. So if there's artifact, you just have to figure out where it is. Typically, there will not be artifact from 60 cycle interference in a new ambulance because the electricity, the electrical components are grounded so they don't cause the 60 cycle interference. The days of the strobes in the ambulance, every time the strobe went off, you'd watch the EKG go crazy and stuff like that. So it's like having a little lightning bolt inside of the ambulance. So again, mostly LEDs, You're not going to really have that. And again, the electricity, the wires are shielded now, so you don't typically see it. So most of the times, patients are cold, they're shivering, their skin they have tremors on the surface of their skin, or we're just moving the wires or something like that. Okay. Okay. So any questions on that first one?
Frank, just quick. When you said,
I'm listening.
terminology. Normally when they print out the EKG, it's unconfirmed until a doctor or a cardiologist reads it. Then it put their name on it, and of course that'd be unconfirmed. Which is the red. That's what that means.
No.
That's
I mean,
to do with
so
computerized EKGs.
So you will see, like let's say in the emergency room, if the emergency room doctor does a 12 lead, he writes his diagnosis. The following day, there's cardiologists that are paid to read all the EKGs. So they may come back and say, no, that's not what it was. It's really this, okay? When the machine that we're using, the LifePak Ping, prints that out, we don't change that diagnosis based on the fact that the doctor says, yeah, that's what it is, because ultimately, he's going to be reviewed by somebody else. So, I mean, I don't know if it's different in New Jersey or something like that, but, we don't change our initial interpretation based on what the machine says or doesn't say, or the fact that the doctor said that's what it is or that's what it isn't. It's just, I think you will get confirmed. Like the other day, I had a guy clearly having a heart attack. So it was, in other words, dummy, anybody would know this. And the word was confirmed, acute inferior wall MI, ST elevation leads 2, 3 in AVF. And it said the big words confirmed. And then on the machine, it was flashing, confirmed. So that was clear. And it wasn't like the machine, was at all confused about it. I think there's criteria it sets for every interpretation. It's like a 15-point criteria. So maybe unconfirmed is 10 out of 15 points were met. I don't know exactly what their algorithm is, but all it means is that not all the points to make the confirmation of the EKG were met. That's all it really means. Okay, so now we're going to talk about the normal rhythms, the sinus rhythms. This will be quick because we pretty much went over it already. Okay, so sinus rhythms obviously have to originate in the sinoatrial node, right? So the sinus node, the SA node. So we said that the rate would typically be somewhere between 60 to 100, but if there's nervous system innervation or interruption or interference, the rate can go below 60, and we would call that a sinus bradycardia, or the rate could go above 100, and we would call that a sinus tachycardia. So if it's below 60, we said one of the reasons is parasympathetic stimulation. If it's above 100, it would be sympathetic stimulation, adrenaline release. So adrenaline is the neurotransmitter, the hormone of the sympathetic nervous system, and the parasympathetic has a neurotransmitter called acetylcholine. So one slows things down, one speeds things up. All a neurotransmitter does is that for some reason we were not made with nerves that go from point A to point B directly. That there are junctions or synapses between each one, and the electrical impulse stops, and this neurotransmitter, this chemical, jumps over and carries the message. So whatever the message is that's going from your brain to somewhere else, there's a chemical every, foot that's going to carry it across. That's the way it is. I think it has something to do with the fact that obviously if you have a continuous nerve fiber and it gets locked up, in other words, the signal doesn't stop. For some reason, the signal just keeps on firing. What do you have? Seizures. Like when people have seizures, a lot of times it's because those synapses don't release the signal, and their muscles go into overdrive because their nervous system is in overdrive. Like when we have organophosphate poisoning or nerve gas poisoning, we learned the sludgem, right? The salivation, lacrimation, all that stuff. None of that's bad. Looks disgusting. They're drooling. Their nose is running. They're not bad. It's when they get into the bad one, which is the seizures. Because what does it do? It interferes. It doesn't allow the nerve impulses to free up. So the person goes into the overstimulation type of setting. And that's where the drugs, the atropine and the 2-PAM and all that stuff come in. They reestablish that junction so that you could break the synapse. Okay. So again, the inherent or intrinsic rate is what it's supposed to be, 60 to 100. Okay. Anything that originates in the sinoatrial node, the SA node, is called the sinus rhythm. So what do we have? It's coming up from this special nerve bundle. I would make it up a little higher. Okay. It's a little low down here, but say up here, this looks more like the junction to me. I don't know why it's coming up that way. Okay, but it goes from the SA node down to the AV junction. Pause for a second. Okay, it goes down into the bundle of His, down into the bundle branches, right? These are these two bundle branches, and then into Purkinje fibers. Now, it makes it look like the Purkinje fibers are just on the wall, outer wall of the ventricle. The Purkinje fibers are like the roots of a tree, and they're through the whole muscle of the ventricles. So they make the whole, not just the outside of the ventricle contract. Everything, the whole part of the atrium is contracting. Okay, so again, SA node to internodal pathways. What's the internodal pathways? It's not showing us too well, but those are the pathways that go inside the atrium. And remember, there's one branch that goes over into the left atrium. Does anybody remember the name? Trivial Pursuit question. What's it called? Bachman's bundle. So I guess there was a Dr. Bachman who figured out there was a bundle. That's how 99% of it gets named, okay? So again, those are the internodal pathways. Goes down to the AV node, which I think is probably what this is here, okay? Brief pause, right, to let the atriums fully empty. Down into the bundle of His, down into the bundle branches, down into Purkinje fibers. So that's what we're looking at. So it's just showing you here the same thing without all the diagram. The intrinsic rate of the SA node we said is 60 to 100. AV junction 40 to 60. Purkinje network 20 to 40, which means any place in the ventricles can fire at a rate of 20 to 40. Some people say that the bundle of His, if it was going to take over, would have a rate somewhere between, you know, like right in here. So like more like the 40, it could be the 40 to 60 or the 20 to 40 if it's the bundle of His, somewhere like right in here. It could decide to go higher, it could decide to go lower. Okay, so normal, I don't know if the best term, some people call it NSR, some people call it RSR, regular sinus rhythm, normal sinus rhythm, but it is the typical rhythm that most people are in, okay? And if we looked at our 5-step, as we go through it, the heart rate, if it was going to be a normal sinus rhythm, should be between 60 to 100. It should have rounded P waves. There should be a P wave before every QRS. There should be a normal P to R interval. There should be a normal QRS duration, and there should be a T wave. And everything's wonderful. And that would be a normal rhythm. So again, heart rate 60 to 100, the atrial ventricular rhythms, so there's a P wave for every QRS, okay? P to R interval is normal, QRS is normal. So you're going to see that the QRS width changes throughout the presentation. I tried to go back. Years ago it was 0.12, then they changed it to 0.10, and now there's even some textbooks and kids that talk about a normal QRS as being 0.8, which would be 2 boxes. So I changed it just to take the middle road in most places to 0.10. So if you see a 0.12 somewhere, it just means I missed that slide. Okay, so somewhere, you know, around 0.10 is what's considered normal now. Okay, so again, same thing they're showing you, that it meets all the criteria to be a totally normal rhythm, and that would be a normal sinus rhythm. So everything is the way it should be. P, QRS, T wave, normal P to R interval, P wave in front of every QRS, narrow QRSs, and a T wave. Everything that we would like to see. Now we said sinus bradycardia just means the rate is below 60. Okay. Why? So somebody vomiting, why would their heart rate go slow if they're vomiting? What nerve do they stimulate? The vagus nerve. Okay. Hypoxia, here it's not the vagus nerve being stimulated. Here it's just one of the fuels of the heart needs to work is not being provided. So oxygen falls, the heart rate drops. Hypothermia, remember we learned whether we can treat somebody with hypothermia depends on 2 things. Their level of consciousness, okay? In other words, are they talking to us? So if they're talking to us and shivering, we can treat them. If they're not talking to us and not shivering, we typically just passively, we take off any wet clothing, wrap them in dry blankets, but we don't actively rewarm them. When they're very cold, one of the reasons why they're not talking to us anymore, besides the fact that their brain is frozen, is also that their heart rate is so slow they're not perfusing their brain that well. Okay, and then they're real big on digitalis. So I don't know if there's any gardeners, but you know, if you're any gardeners, some people grow digitalis in their garden, right? It's called foxglove. It's a plant. So it's one of the earliest plants that's been identified to have medicinal purposes is the digitalis plant. It's actually in, you know, back from, you know, ancient times, and I guess somebody, you know, chewed on the leaves of these plants and became very bradycardic, and somehow they put 2 and 2 together that it had some heart effects. But digitalis is one of the plants, okay, that can, one of the drugs that can cause a slow heart rate. It was a very common treatment for atrial fibrillation, because we said one of the problems in atrial fibrillation is that if the heart rate starts going too fast, right, the ventricles don't have time to fill up blood. So they used to put them on DIG, and DIG would do 2 things. It would keep their ventricular rate slow enough, right, not too slow but slow enough, and would also improve slightly on the contraction of the heart. so it would make the heart contract with a little more force, so it would keep their blood pressure up. It's a drug that's very hard to keep in a therapeutic level. So you talk about, say the term digitoxicity or digitalis toxicity, right? Everybody has heard about that in their life. They used to get yellow halos, and any EKG is possible, any heart rate is possible when somebody has digitoxicity. So, but that's one of the things that they talk about is causing it. Opioids can cause slow heart rates. Obviously, the bigger problem with opioids is what do they slow down besides heart rate? Respiratory rate, right? Remember, so decrease in mental status, decrease in breathing, pinpoint pupils are the three classic signs. One of the things just to recognize now with as far as opiates is that they're finding that the Narcan can be just as dangerous as the opiate, right? In other words, too much Narcan, okay? And this is really coming, and not to pick on any one particular segment, but the cops.
One in each stuff.
Exactly. So it's like the first cop comes and shoots him in both nostril, and then the next guy wants to get his name in the newspaper too, so he shoots his in the nostril. And what's happening is then you have this sudden withdrawal. And when they have this sudden withdrawal, they're finding two things. They're getting hypertensive, okay, and they're going into what's called acute respiratory distress syndrome, ARDS, ARDS, and they go into pulmonary edema. So there's more and more talk about the dangers, and it just comes down to a little more, you have non-medically trained people being allowed to administer medications, which was a gut reaction to the rate of death that was happening, right? If you go back a year ago, there were people dying every day, so they had to do something, so they just said everybody can use it. I mean, now you can even get it in New York without a prescription. You can go into CVS, $35, you have Narcan. So maybe now it's time to relook at it, and instead of giving them 15 bullets in their handgun, maybe we're going to give them a 0.5 milligram in Narcan instead of 2 milligrams in the syringe, and maybe it won't be as bad, or we'll put some kind of restrictor on the syringe that you can't push it fast or something like that, because that's the big issue. And it goes back to the days when we used to give it IV. People used to give it IV, and there was a big joke to give it as fast as you can and see how high they vomit. In other words, so the same thing's happening, but just now from a different reason. Okay, so again, we said it may be normal in healthy people, and again with sleeping, eating, and stuff like that. So that's the sinus bradycardia. Now, could a sinus bradycardia be dangerous? Well, if your heart rate is normally 100, right? Most of us, our normal heart rate is not 60 to 80. It's 80 to 100 because we're not in good enough shape. Okay? So if your heart rate is normally 100, and for some reason now it goes down to 50, so half your normal heart rate, are you going to feel tired and weak? Yes. Could you faint? Yes. So again, some people may just slow down their heart rate too much. Remember that formula for cardiac output is always heart rate times stroke volume. So if you're dropping the heart rate and you're not increasing the stroke volume, you're going to drop the cardiac output, which is the amount of blood that's pumped out in 1 minute. If you're dropping your cardiac output, you may not get enough blood flow to the brain, which would then mean you would syncopize, right? You would pass out. So not all sinus bradycardia is normal. And we already know, we go on calls occasionally for the person who was straining on the toilet and they braided themselves down and they passed out from, right? So there's different reasons why you may go on calls where people have bradycardia. Most sinus bradycardia is not dangerous, okay? But if you go on a call where the patient says to you, when I'm lying down in bed, I feel fine, but if I try to sit up, I feel like I'm going to pass out. Right off the bat, that's positive orthostatic changes in their blood pressure. We don't have to, hold them up with two guys holding them up and take their blood pressure at that point. That's positive orthostatics. If the room starts spinning, okay, when they sit up, okay, it's positive orthostatics. It could be, that they're having some type of inner ear problem, okay, right? It could be, but if the story was that the room, I should have said the room was spinning because that always leads us towards like a vertigo or something like that. But let's just say that when they sit up, they feel weak. That typically can be a slow heart rate. So there they would be symptomatic, and we'd have to figure out what rhythm are they in to know how to treat them in that situation. Okay, fast heart rate, sinus tachycardia. Okay, definition usually say 100 to 150. Here it says 100 to 160. Again, could be the normal response to exercise. Sympathetic stimulation from fear or stress, being nervous, okay, any kind of stimulants. I mean, if you have caffeine in the morning, your heart rate will typically go up about 10, 15 points, okay, unless you're, if you're drinking 4 cups of coffee every day and you're not close to your 4th cup yet, you're probably not going to get much of an increase in your heart rate. But, if you exceed what you normally take, you'll usually get a little bit of a increase in it. But then it can be compensatory, right? So compensatory, we said that it's keeping the blood pressure up in shock, okay? In CHF, it's more probably fear because they feel like they can't breathe, okay? Again, in dehydration, keeping the blood pressure up. Or normally people having a heart attack, I wouldn't say their heart rate's close to 160, but their heart rate typically is above 100 because they're scared, right? I mean, you know something's wrong. You got this discomfort in your chest. Is it good for somebody having a heart attack to increase their heart rate? Is it compensatory in that case? No, right? It's bad because if you increase your heart rate and your heart is damaged or in the process of being damaged, you're only going to have more damage, which is why a lot of times in heart attack patients, they'll actually give them beta blockers to slow down their heart rate so they don't overtax their heart. Okay, so that's the sinus tachycardia. Now we have a couple of very rare ones, okay, but not necessarily dangerous. A sinus dysrhythmia is where the R to Rs change slightly with breathing. And most of the times it happens in young, healthy people, okay? It's where your respirations slightly interfere, okay, with the rhythm of your heart. Not a bad thing. Most of the times it's missed. Okay, let's see if we could see an EKG. So if you look at it, it's almost, right, regular, but you see like one is a little early. I think there was another one. I'm looking at it from an angle. Yeah, maybe over here a little bit. Okay, so it's typically on inspiration, okay, the change in the pressure in their chest slightly throws off their EKG. No significance, okay, no big deal. It's just a normal response to breathing, and again, it typically happens in young, healthy people. You could have something called sick sinus syndrome. Okay, so what does it mean? Your SA node is getting old, okay, it's not working properly, so you may get somebody who has slightly altered, okay, but most of the times it's breathing, okay, most of the times it's breathing. So it varies with respiration, typically young healthy person, no big deal. Now, sinus arrest rhythm, very rare, but this sounds a little more ominous. So arrest means what? That somehow or another the SA node is not firing when it's supposed to be firing, right? So there's an absence of a whole PQRST complex noted. So what are you having? A normal beat, normal beat, normal beat, normal beat, and then all of a sudden a pause, and it skip one whole cycle and then start firing up again. The fear is that if it does that a lot, that the heart rate's going to slow down. So in other words, if the sinus node arrests more regularly, that you're going to could have a systole, right? If it just decides to shut down completely. So if the sinus node stops, hopefully what's going to happen? That a pacemaker site below it will take over. And then that's called an escape complex. In other words, if you have where the sinus node does not fire when it's supposed to fire, and someplace lower down in the conduction system takes over, that would be called like a backup or escape rhythm that's designed to do that to keep the patient alive. So we'll see those as we go on. So I've never really, be honest with you, in a patient saw sinus arrest. They do say it's an aspirin toxicity, salicylate toxicity. Sometimes you'll see it. Okay, again, digitalis is going to get blamed for everything. I've never seen it as a result of an acute MI. I've seen people get bradycardic, typically inferior wall MIs, which is the bottom wall of the heart. Instead of getting tachycardia, they typically get bradycardia because the vagus nerve innervates that area. So they typically get bradycardic. But I've not seen sinus arrest rhythms in it. Okay, so it depends on how many impulses are being blocked, on how symptomatic they are. But it's very, very infrequent. Okay, so what do we have? Normal, normal. Okay, and then nothing happened, and then it starts again. And the question is, how often does the SA node? Now in this one, there was no escape pacemaker, right? When the SA node didn't fire, what do we get? Flat line. Right? Isoelectric line. Iso means nothing. So isoelectric line means there's no electrical activity. So depending on how many complexes, this is probably 2 or maybe even 3 complexes that did not fire. If that continued, what would we have? A systole across the monitor. But it's not, again, not a very common type of thing. But if you saw that, where all of a sudden, you got PQRS, and then just flatline, your next thing should be look over at the patient. Are they awake or not awake? Okay, and if they're awake looking at you, then it's probably a problem with the wires being disconnected. All the new monitors, when the wires get disconnected, what happens? It beeps. So the old machines, would always be check the patient and then check the wires. The new machines are going to tell you, not only is it going to beep, it's going to tell you what lead is off. That's how, you know, fancy they are now. So they'll even tell you, you don't have to undress the patient to find which leads they are. If you have them wrapped up in blankets, it'll tell you, you know, left leg, right arm, so you can just get to an isolated area. Okay, so.
What would that present as for the patient?
Well, it could present as a patient who says, the family wife calls you and says, every so often, he just nods out. You know, like I'm talking to him and all of a sudden just, and I call his name, Frank. You know, it's not just you're ignoring your wife type of thing, right? So it's like all of a sudden, boom. And then, so now you have an excuse. You could say, I'm sorry, I was not ignoring you, sweetheart. I have sinus arrest. And that is why I went to sleep, right? Exactly. So.
Why doesn't the IV know treatment?
Yeah.
That's the question. So why does that's the exact question. We don't know. In other words, why does a pacemaker site below not fire? So maybe if it goes on for a longer period of time, you would get an escape pacemaker to fire, or maybe, you know, it doesn't. I don't know. I don't know the exact reason why. Normally, when you start seeing slow heart rhythms, you are going to see the junction start to fire. So they're going to switch from a sinus rhythm to a junctional rhythm, which is going to look like the same thing as a sinus rhythm, except the P wave is not going to be there, or it's going to be inverted. So we're going to see those in a second. So good wife story. So I don't know if anybody noticed, but I was soaking wet when I came in. I'm still squishing in my. So at the height of the thunderstorm, I hear honk, 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 and I look out the window, and there's my wife's minivan in the driveway. And I'm like, she's got to be kidding. So all of a sudden the phone rings, and she goes, you have to come out. I really need to go to the bathroom, bring an umbrella. Whoa. So I'm saying, what would be the consequences of not doing this? You know? And I'm looking, and the lightning is striking across, and I'm going, so I'm going to go outside with this thing that conducts electricity. So I said, okay, you know, whatever. So I go out there. You know, it's raining sideways and all this stuff, and I'm standing by the door, and I'm like, come on. She goes, the rain is still coming under the umbrella. I said, yes, I know. She goes, can you hold it higher? I'm like, the lightning, you know? So she opens the door, and she proceeds to make it was like a 5-yard dash, but she proceeds to run. So I'm like holding the umbrella, and she's in the house already, and I'm like, okay, so this was stupid. So I put the umbrella down and just, you know, walk in the house, and I said, you know, you would only understand it if you were married. You know, so. Okay, so sinus rhythms, we're not going to treat the patient. I have to remember that we're taping this, and I keep on forgetting that we're taping this. So the only good thing is that she would never listen to me talk this long. So if we're that long into the video, she'll never listen. Okay, so again, we're not treating the patient. We're treating how the patient tolerates the rhythm. So if they're in a sinus rhythm, it does not mean they cannot be ill, right? They could be having a heart attack and be in a sinus rhythm. So we always have to take that into conjunction with all our other assessment of the patient. So just don't think just because they're in a normal sinus rhythm that they're going to be fine. Okay, so again, sinus bradycardia, if they're symptomatic, they're showing signs of lack of perfusion, right? Decreased cardiac output. Oxygen, if their pulse ox is below 95%, we're going to have to give them drugs on the ALS level, so we're going to think about getting an IV. And the drug that we would use is a drug called atropine. A lot of the BLS ambulances for quite a while had atropine on there as a nerve gas antidote, okay, which is one of the things it's good for. But atropine is a parasympathetic blocker. So if the cause of the bradycardia was excessive parasympathetic stimulation, and you give a parasympathetic blocker, what are you going to do to the heart rate? Increase it, right? So remember, we said one of the reasons somebody can become bradycardic is excessive vagal tone, parasympathetic stimulation. Giving somebody atropine, if the cause was the vagus nerve, you're going to increase the heart rate. If the cause was hypoxia, giving them oxygen would increase it.
Why epi?
If the cause, because what does epi do to the heart? Overstimulates it. So we really only use epi in life-threatening situations. So epi is going to be cardiac arrest to really stimulate the heart, or anaphylaxis, maybe a dying asthmatic under the new collaborative protocol. Okay, but other than that, we typically do not give epi to alive people. It'd be very rare. It's like the stress test of your life. I mean, to get epi, you're putting a massive strain on the heart. So in kids, the opposite. Kids have a young, healthy heart. So bradycardia in kids is not usually parasympathetic. It's typically you have to directly stimulate the heart with epi, and they have a healthy heart, so you don't fear giving it. With us, we have no idea what the status of our coronary arteries are unless we had a cardiac angiogram done. So we don't know if our arteries are 10% blocked or 70% blocked, right? I mean, we don't know. So you give somebody a shot of epi, and you're going to find out, right? That's what it comes down to. So.
What's TCP?
TCP is transcutaneous pacing, okay? So what that means is that we take the same pads that we use to defibrillate, and instead of hopefully remembering not to turn the defibrillator on, we turn the external pacer on. And instead of shocking them at a high energy level, it sends a much smaller energy level through their skin to stimulate the heart externally to beat. So in other words, you're sending a little shock of electricity to actually stimulate the heart to contract, because you're saying that it's not contracting enough times a minute. So this would be something to do to someone you don't like, right? So basically it would be like electrical torture. I mean, it's so. I mean, I've not done it very frequently, but the last time I did it was this very, very nice little old Jewish grandmother whose heart rate was very, very slow, and all the way to the hospital. Every time the machine shocked her, she went, "Oi, oi, oi." So I walked in, the doctor's like, "How's she tolerating?" I said, "Wonderful." I said, "She's only now having an oi attack, but her heart rate is about 90. And he goes, "Well, what's an oi attack?" I said, "Come into the room." And then she goes, "Oi, oi." He goes, "Oh, we can treat that, So they gave her some pain medication, and then her oi went away. We typically don't give them pain medication because pain medication can slow their heart rate, and the reason you're pacing them is to increase the heart rate. So this lady then wound up getting a transvenous pacemaker. In other words, the cardiologist came in and put a artificial pacemaker, device in her chest, because her pacemaker system just stopped working, and she was depending on her ventricles to fire now, and it was firing very slow. So most of the times this would be the right order. Oxygen, obviously get a line, try some atropine, okay? You give usually up to about 2 to 3 milligrams of atropine, and then if, you could also try transcutaneous pacing. Okay, sinus tachycardia, okay, again, it could be a normal compensatory mechanism. It could be fear. What we're concerned about is that when somebody's heart rate goes that fast, the amount of oxygen they need increases. Right? So it's called myocardial oxygen demand. When you are making your body work faster, you need more oxygen, right? We have aerobic metabolism, we need oxygen and sugar. So when you're making your heart work harder, you need more oxygen. So if you can't get that more oxygen, then you have what's called a ventilation perfusion mismatch. You need more oxygen, you can't have more oxygen, and what will happen in the muscle if you're not getting enough oxygen? You'll revert from aerobic metabolism to anaerobic metabolism. What will build up in the heart? Lactic acid, and what will you get? Pain, right? And that is how somebody could overexert their heart and get pain. When you go on a stress test, right, what are they trying to do? They're trying to make you overexert your heart and see changes in the EKG that would tell them that the heart muscle is not being perfused. They don't want to actually make you stress your heart to the point you have pain. They could see the changes in the EKG, hopefully before you get pain, but that's what they're trying to do. So the EKG is showing them the sign of the increased myocardial oxygen demand, and that's where you would actually see the ST depressions, okay, or the ST elevations. Okay, so it can precipitate myocardial ischemia. In other words, if you increase the myocardial oxygen demand and don't meet it, the heart will get ischemic. Ischemic means there's not enough oxygen going to it, and then you could have damage or death. Infarction means death, right? So when somebody's in a sinus tachycardia, we don't treat the sinus tachycardia. We treat the reason they're in the sinus tachycardia. So if they're scared, we calm them down. Okay? If they're dehydrated, we give them fluid. If they're in shock, we stop the bleeding. So in other words, we don't treat the rhythm. If we treat the reason why they're in it, then of course what's going to happen to the heart rate? It'll slow down. So you never suppress a sinus tachycardia. Now, the only thing I will mention is because of all these new drugs that are out there, especially the K2, the synthetic marijuana, that seems to be the new one. I don't know if you've had that yet, but the synthetic marijuana is the new. I mean, you saw it happen in Queens last weekend or something like that. So what they basically did is that they chemically isolated the substance, the THC substance in marijuana. Okay, recreated in a laboratory at Clemson University back in I think it was the 1990s, 2000, under the idea of a medicinal purpose for treating cancer and stuff like that. So you wouldn't have to, because marijuana was illegal then. So they wanted to have something to treat cancer patients and, increase their appetite, make them more comfortable without having with skirting the laws around marijuana. The problem was that it didn't have the same effect. So marijuana typically is a mellowing effect, and just isolating that one substance actually has an amphetamine type of response. So amphetamines typically do what? Increase everything. So now what they're doing is that formula back in the days before September 11th, everything was on the internet. You had to publish, right? Publish or perish in research. So they published the whole thing, And some, smart people in, I don't want to particularly say any countries, but Russia, Mexico, somewhere, got the formula. They recreated it, and they now take it and they spray it on anything, oregano, whatever, so people smoke it. So they could be smoking any plant substance, and the stuff is sprayed on it. You sometimes will even see it on stamps, so it'll look like a kid's sticker, and they'll spray it on like the gluey substance on it, so they'll lick it. So if you ever see somebody walking around licking kids' stickers, it's probably got some type of drug. Ketamine is another very common one they'll put on there. And what happens now is when they go into this amphetamine type of effect, they can get sinus tachycardia. So it's not a compensatory effect for dehydration, it's a response to the amphetamine. So there you might see people coming along and saying, whoa, his heart rate's 180, we need to slow it down. So I just didn't want to confuse you. So you may see somebody who's in a sinus tachycardia. Here they're slowing it down because what's it doing? It's increasing the amount of oxygen their heart needs. So that's why they're slowing it down. And that's what's actually, most of the treatment of all this K2, all the synthetic marijuana overdose is actually what they call supportive. So what you basically do is give them something to mellow them out, give them something to slow their heart rate down, let them sleep for a couple hours, and the drug wears itself off. You let them loose, and they probably do it again, in another hour or two, but, you treat it what the problem was. So, okay, again, sinus, what'd you say?
Give them real marijuana.
Real marijuana.
Up in Harriman in the summer, they have all those camps. So I go up there like 3 o'clock in the morning for a party having a stroke. And it's, like 5 girls and this one, like, really clean-cut, born-again Christian kid from Georgia. And so basically he comes up here, to an environmental internship in the park. And he's got these 5 streetwise girls who, he's good looking and everything, so they decided they're going to widen his horizons. And so basically they give him first they gave him a beer, but then they escalated from there. So by the time whatever he took, when I get there, he tells me he's having a stroke. And I said, really? So what is a stroke? And he goes, I don't know, So he's like telling me all these symptoms and all this stuff. And, and all the girls are running around trying to put clothing on and stuff like that, and park police show up and everything. And I'm like, oh, it's just teenage hanky-panky, and stuff like that. But he says, I said, listen, you're not having a stroke. This is what happens first time. You're going to be fine. I said, we're going to just send you to the hospital anyway. He goes, oh, we have a problem. I said, what's the problem? So I forgot his exact last name, but the town he grows in his driver's license, the town that's on his driver's license is his last name. So he says, here's the deal. I live in a town of like 150 people. My father and his father before him and his father before him was the pastor. He goes, I cannot go to the hospital. Nobody could find out. So I said, it's Obamacare. Don't worry about it. I said, they're never going to find out. I said, you just go there, tell them you have no insurance. They got to take care of you. I said, make up any name you want. I said, in fact, tell them it's Goldstein. I said, they won't even blink their eyes in this hospital if it comes in Goldstein or something like that. And he's like, really? I'm like, I'm telling you, dude, listen, we all did this, it's part of growing up. And I said, the other thing is when girls are offering you things, I said, and it's things you don't know, I said, don't think. So all these girls are like so upset, like I can't believe we did this to him. I said, when he comes back, there's many ways you could make it up to him. I said, and I'll leave it at that. So the sergeant's going, you should do stand-up comedy. He goes, this is like better than anything I heard, And I'm like, hey. So we're walking him out to the ambulance. Ed, were you on this one?
No, but no. Christmas.
Yeah, and I think, what's his name was Sean.
Yeah.
But so as we're walking him out to ambulance, he goes, I really don't think I need to go. I said, listen, you need to go because you're going to call us back, and I get cranky, if I got to come back out. So as we're taking him out there, he starts throwing up all over the place. And he goes, I feel 100% better now. I said, the problem is the vomit attracts the bears. The kid beat us to the ambulance. So that was it. And the girl's like, bears? I said, come on, everybody pile in. We're going to have a party, So, okay, so again, sinus arrhythmias. Every time I've seen it, it's been a teenage kid, early 20s, healthy, changes with breathing. Of course, the question I would ask is, why are we taking care of a young, healthy kid in their 20s? So typically we don't, but it's for whatever reason, you have this kid, you put him on the monitor, you see it, nothing really to worry about. Sinus arrest, again, very rare, okay? But if it's prolonged, okay, and happening, you may have to treat them the exact same way you treat the sinus bradycardia, okay? Not that it probably is going to work, the atropine, they probably have to go onto a pacemaker, a transcutaneous pacemaker for it, but the nice thing about the transcutaneous pacemaker is you could set it as a standby, which means that you could set it for a heart rate of 80. Put it on the patient. It will do nothing unless the patient's heart rate goes below 80. So typically what we'll do is we'll set it for 60. Okay, put it on the patient, set it for 60, and if at any point the patient's heart rate starts to drop below 60, it'll start firing and pacing the patient. So you can put it in a standby mode. Okay, so let's take a 5-minute break, stretch your legs, okay, and